Thank you for that introduction. As you said, my name is Bojosi Gamontle, and today I'll be presenting some of the findings from my PhD research. And the title is Perspectives of Botswana Healthcare Workers Towards Tuberculosis Infection Control and Occupational Health Measures, and this is an interpretive descriptive study. All right, so just to give you a heads up, I'll be going through the background, some selected literature review, research questions, methodology, some findings because we can't cover everything today, and some of the recommendations that came from our study. All right, so to begin, let's look at the scope of TB globally. So basically, TB is actually one of the oldest diseases in human history. But having said that, it still kills over 2 million people globally per year. And lower and middle income countries are disproportionately affected in the sense that 90% of TB cases in the world are actually in these countries. And just to give you an example here, when you look here at Botswana, which is considered a middle income country, has 478 cases per 100,000. And if you compare that to Canada, here you'll see that it has 4.7 cases, back in 2011, 4.7 cases per 100,000, which is 100 times less compared to Botswana. Right? So that's in the general population. Although in Canada, for instance, there are communities which have higher incidence of TB, but that's the state of things. All right, so looking at TB now, what is TB? What causes TB? TB is caused by a gram-positive bacteria called Mycobacterium tuberculosis, and it has this, bacterium has a thick lipid-rich cell wall, which we'll talk about in the next slide, which helps the way that TB is transmitted from in the environment. So TB is transmitted through the airborne route. So when a person who has TB speaks or coughs or sneezes or sings, they release bioaerosols, which in hygiene, that's what we call them, bioaerosols, which is particulate matter, with a range of particles, different sizes. But the ones that we really particularly want to look at or want to talk about are the 1 to 5 microns, which are in the respirable size particles. So that's what we call them in hygiene. In infection control, they call them droplet nuclei. So anywhere in the presentation, when you hear me talking about droplet nuclei, I'm talking about it's the same thing. So these particles, because of their size and because of their properties, they can be suspended in the air for hours. And so under normal currents, under normal airflow, they can flow from one area of the room into the other, which makes them really important for study when we're talking about transmission in particular. So on the side of the person who is exposed, if they inhale, the route of exposure is inhalation. If they inhale the tubercle bacilli, it goes, because of its size, remember it's respirable, because of its size, it goes deep into the alveoli here, as you can see. And it's taken by macrophages and begins to cause localized infection, or taken by macrophages to other parts of the body. And where it ends up, the location where it ends up, determines the kind of TB that we talk about. Mostly for this particular presentation, we're talking about pulmonary TB, but there are other kinds of TB, meningeal, bone, and others. So then the infection, whether the person gets infected, the person who's exposed gets infected or not, depends on the concentration of the bioaerosol, and also it also depends on the immunity of the person. But what is to note here is that if a person is infected, they can begin to have what is called active TB, which means they can begin to show signs and symptoms of TB. They can also be latent. They can be infected but not have the signs and symptoms, which is called latent TB. But what is important to note here is that in people who have latent TB, they have the 10% risk of developing active TB in their lifetime. So it is important, particularly for healthcare workers, because if you're working in a hospital and then you leave with latent TB, it may develop it. So it's really important to know that. So now we'll look at some of the risk factors, or people who are at risk, at high risk of developing, being exposed to TB or developing actually signs and symptoms first. So for people who have active TB then, usually they present with loss of weight, excess loss of weight, fatigue, night sweats, a cough lasting over 3 weeks. In fact, TB, way back, it used to be cold consumption, or phthisis in Greek, which basically talked of the severe wasting and coughing of blood during the later stages of the disease. Okay, so now we're talking about those at risk, people at high risk of exposure to TB or infection. Right, so persons with comorbidities, for example, HIV or silicosis or diabetes. HIV in this particular case is really important to what we'll be talking about today, because HIV increases the risk of a person who has HIV is much more likely to develop active TB. Residents or employees of congregate settings are also at risk, such as correctional facilities, long-term care facilities, and homeless shelters. Here in Canada, in particular, it is known that people who are homeless are at a high risk of developing TB, and also in Aboriginal communities. Medically underserved and low-income populations, infants, children, and adolescents exposed to adults who have TB or at high risk. Persons from regions with high prevalence of TB, as we saw in the map, that TB is disproportionately spread out globally. So people who are from countries where there's high levels of TB are likely to be exposed and have TB. And lastly, healthcare workers serving high-risk patients. And that's basically going to be the focus of what we'll be talking about today. Specifically, healthcare workers who deal with procedures such as bronchoscopy and sputum induction, where there's aerosolization of aerosols. So those are at risk. All right, so now we're going to look at the story of TB in healthcare workers and some of the literature review that we did for this. All right, so basically, if you look back in the history, the 17th and 18th century, in Europe, there's the White Plague, which was TB outbreak, which basically wiped almost everybody who was exposed or who was infected. But going back into the 50s and the 60s, because of the use of chemotherapy, TB was relatively under control. Until the mid-80s, when HIV, at the advent of HIV, then TB rates increased. And it also came with different strains of TB, such as multiple drug-resistant TB and extremely drug-resistant TB. So then in North American countries, what happened was because healthcare workers in particular are at the forefront of serving patients who have TB, they begin to realize that healthcare workers had increased rates of TB. And they used molecular techniques to evaluate or to see how this was. And so it was, it was obvious that healthcare workers are being exposed, or they're getting TB from their patients. So in high-income countries, I should say, what they came up with infection control measures and occupational health measures, infection control measures such as negatively pressurized isolation rooms with proper air changes and personal protective equipment to protect the healthcare workers. And so they realized that, in fact, the rates of TB among healthcare workers was reduced. In lower and middle income countries, however, because of the HIV burden and the weakening of healthcare systems by HIV, these measures were not able to be put into place because of lack of resources. So then we found that in lower and middle income countries, as I mentioned before, there are high rates of TB. But the paradox here is that there's lower documentation of these cases in middle and lower income countries, although this is beginning to change. You see in Malawi, for instance, that they did studies that show that there was high incidence of TB in healthcare workers. If you look at the rates, over 5,000 in 100,000 of those cases were healthcare workers, compared to the general population, which is maybe 240 per 100,000 in the general population. So for this particular study in Malawi, they concluded that the guidelines that were supposed to be used for infection control were not being implemented. One country, the sub-Saharan Africa, that is producing a lot more studies in this particular area is South Africa. And because of South Africa also is known as, if you take Africa as a whole, is in the top country, if not even the top 5, or even the top 2 countries where there's high rates of HIV. So that TB, then there are high rates of TB in the general population. And the studies that they've done have shown that there's high rates of TB in healthcare workers as well. So we wanted to know, with countries surrounding Botswana in particular, with showing this high levels of TB in healthcare workers, what's the situation in Botswana? Right. Given that Botswana also has a high incidence of HIV, that's what we wanted to find out. We also found out that TB in the general population in Botswana had over 400 per 100,000, as I mentioned earlier, in the general population. But there were no studies that talked about the incidence of TB in healthcare workers. Also, there were no perspectives of what healthcare workers are saying concerning exposure to TB, or there were no evaluation of guidelines as it has been done in other countries, in South Africa, for instance, or even here in North America. So that's what we wanted to find out. I mean, we had wanted to determine the incidence of TB in healthcare workers, but later, as you'll see, we couldn't do that because that data does not exist. Right, so our research questions that came from this then, what are the perspectives of policymakers and hospital leaders towards occupational health and infection prevention and control measures used in the prevention of TB, for healthcare workers in particular? The second one was, what are the perspectives of healthcare workers themselves who have direct contact with TB patients toward occupational health measures and infection control measures? So this was a primarily qualitative study. We used a methodology called interpretive description, which derives from grounded theory. And if anyone is aware, has any knowledge of qualitative methodology here, interpretive description comes from grounded theory, which comes from sociology and is primarily used for deriving theory out of the view of participants. So then the difference with interpretive description is that those key statements that are derived from participants are used to inform clinical understanding. So we use coding techniques by Miles, Haberman, and Saldana. And what coding does for qualitative research is you begin to tease out the data, then put it back together and synthesizes and begin to see waves and patterns and categories that you can use in the end to inform clinical study. And in qualitative research, it is particularly important to make sure that you have what is called trustworthiness of the data. And one way of doing that, of ensuring that this trustworthiness of the data, particularly if you're using interpretive description, is to be rooted and grounded in the field from which you came. So we made sure that we remained truthful and faithful to the fundamental tenets of occupational hygiene for us. All right, so the data collection happened between March 2012 and November 2012. We went to two hospitals, two public hospitals. One is called the Referral Hospital, which is a major hospital in Botswana. There are three referral hospitals in the whole country. So we went to one of them. It has a capacity of over 700 beds. And we also included a district hospital, which is about 500 beds or less. And we also included one private hospital and Ministry of Health headquarters. So we conducted 21 interviews with hospital leaders, with TB policymakers, with infection control leaders and occupational health personnel. We also conducted focus groups with a total of 40 participants. These were five focus groups, and we divided them into two. So for the two public hospitals, we had two focus groups at each of those hospitals. One focus group was with healthcare professionals such as nurses, lab technicians, radiographers, and the other group was with hospital cleaners and drivers and auxiliary nurses. So we had one focus group at the private hospital, which was just with the cleaners and with the auxiliary nurses. So two of the focus groups were actually conducted in Setswana, which were then translated to English, and everything was transcribed verbatim. Right, so we used NVivo 10 for data management. I should also mention we collected some guidelines, TB treatment guideline and other guidelines, but we're not going to get into that for this particular presentation. But we evaluated those using a standardized tool, which actually comes here from Canada. It's called the Appraisal of Guidelines for Research and Evaluation. Right, so now we're going to get a little bit into some of the findings that we have. So as I mentioned before, the aim of coding is to begin to see themes and patterns in your data. So we saw different themes, and today I'm going to only focus on these. And I should mention here that these themes derive from what participants said, what participants mentioned. We had limited or no occupational health services. We had no evidence of occupational TB exposure for healthcare workers. We had infection control, and we had barriers to implementation. All right, so before I get into no or limited occupational health services, I wanted to show you this diagram, which basically talks to the overview of some of the legal instruments in occupational health that are currently used in Botswana, or back when we collected data. And I also wanted to mention too that all this data came from the participants, and we put it together to have this. Right, so in 1973, Botswana promulgated the Factories Act, which basically looks at factories, and it includes occupational health measures for workers in a factory setting. And I wanted to particularly focus on the ones that are important for today, such as the Public Health Act of 1981. The Public Health Act doesn't necessarily have a section that talks about occupational health, but it does, however, cover if, for instance, a TB patient absconds from the hospital and leaves before their treatment is completed. It gives the healthcare workers and the law enforcement the right to go and get that patient and take them back to the hospital. Another instrument is in 2004, in fact, the Ministry of Health, particularly the Environmental and Occupational Health Department, came up with a draft of occupational health and policy draft for the nation, but it was never promulgated because of stuff that I'll get into today. So then the Radiation Protection Act, which particularly focuses on exposures, radiation exposures for healthcare workers within the hospital who are dealing with radiation, radiographers and the like. So the last one here that I wanted to mention is the National Occupational Safety and Health Policy of 2012, which in 2012 was in fact a draft policy, in a draft form. I had a chance to look at it, but I didn't evaluate it because I was specifically told it's not official yet, so don't even do that. All right, so under the theme of limited or no occupational health services, we found that 2 of the 3 hospitals actually had no occupational health service, occupational health and safety program, whether committee or anything of the sort. But however, the hospitals, the government hospitals at the time we were collecting data had in fact just introduced environmental health officers in the hospitals who were supposed to take of environmental issues like air quality and stuff, but there was no particular occupational health and safety. One hospital did have a committee, and we actually interviewed the chairperson of that occupational health and safety committee. All right, so we also interviewed an occupational health and safety officer from the Ministry of Labor and Home Affairs who was really instrumental in some of the stuff that I showed you in the last slide. And we also interviewed a public health specialist in the occupational and environmental health department, the Ministry of Health. All right, so I wanted to share with you some of the quotes that came out from the data, in particular when we're looking at limited or no occupational health services. So this person who's a health administrator, the occupational health and safety officer, said, well, the issue of occupational health and safety in this country is fairly new. And he goes on to say the issues of occupational health and safety in total, they're only seen as additionals because when you look at the planning of any organization, occupational health and safety is only considered as any other business. It's not the main part. It's not the part of the business agenda. So which goes to show how, the reason why there's limited or no occupational health. So this one, the public health specialist says, leaders have got their priorities, talking about policymakers. Unfortunately, public health is not a crybaby in the world of health. It is clinical services that are crybabies. You need drugs to treat this. We need to operate these. Theater, you need, evaluating, following up, preventative activities are done. And he says prevention activities are done when children have gone to bed if you have extra time. If you're too sleepy, just sleep. We know we can use that kind of analogy when we're talking about public health. Now, this is a physician in the private hospital. He says, we certainly do know that as an occupation, there's a lot of occupational hazards for healthcare workers. And there's a tendency to look at other workers like in the mining industry and so forth, but without paying much attention to healthcare workers. So yes, I generally feel that healthcare workers in this country, certainly in various institutions, are shortchanged. He's talking about mining industry here, and if you remember back at that diagram, we started with the Factories Act, so it kind of shows that that Factories Act maybe had a role to play in that regard. All right, so then when we looked at the literature review in the region to see what they had to say, in particular looking at limited or no occupational health services, Lucchini in London in 2014 said majority of workers in industrializing countries work under subpar conditions. They said less than 10% of countries in lower and middle income countries have sufficient occupational health services. So what we found is it's not really new, it's already there. And Osaratin, Owe, and Apanga said in lower and middle income countries, occupational health services are not implemented because there are many economy-related issues. There are many competing health issues. So for people to just focus on occupational health, and if we're talking about TB, to just focus on TB. We also found that there's lack of specificity, if I can use that term, for occupational health services. And we say that because there was, when you're talking to participants, there was blaring of occupational health and infection control. in the sense that in some areas it omitted some of the fundamental aspects of occupational health. For instance, we found some studies out of South Africa that they talked about occupational TB exposure studies, but you'd find that there's really there's limited occupational hygiene or occupational health in general if you look at those studies. All right, so moving on to another theme, no evidence of occupational TB exposure for healthcare workers. So participants, particularly the in-depth interview group, believe that there's no evidence of healthcare worker TB. There's no evidence that healthcare worker TB is occupational, it's nosocomial in other words. They said this because, because there's a high HIV comorbidity in the country as a whole, people who are having TB as healthcare workers could be that they have HIV as well. And also they could be exposed in the community at home, with people they're living with. In the private hospital, they were not admitting a lot of TB patients. So they said they really didn't find any use to have any occupational health program or even to begin to think about occupational health exposures in healthcare workers. But they did, after our study, they did say it's something that they're considering to do. So another thing is that the national system records TB, this is the Botswana National TB Program, has a TB registry. So basically every person who goes through the health system who has TB is recorded in this system. But what happens is that the form that they use doesn't record occupational title. So there's no way of knowing whether this person is a healthcare worker or they're not working, or there's no way of knowing that. However, TB coordinators do have information about TB in healthcare workers. They do know that, this person was working in this area and they had TB after such and such. But nationally, there's nothing. All right, so now for some codes that are coming from this theme of no evidence of occupational TB exposure for healthcare workers. This physician said, no, unless there's evidence that people who have TB, talking about healthcare workers, get it in the hospital, then the healthcare workers have a case to fight the government to get an incentive. But other than that, it's not going to be possible. But I think it would make a huge difference because you get a lot of healthcare workers who don't want to manage TB. They're just like, yeah, TB maybe, but multi-drug resistant TB and extremely drug resistant TB, no. They don't want anything to do with that. This TB coordinator had somewhat of a slightly different view. She said it's really hard to say, she kind of agreed with what they're saying, but she went on to explain why, there's a slight difference in the situation here. It's really hard to say these people will be getting infection from the patients, talking about healthcare workers. But at the same time, we've realized that there are some of the healthcare workers who are always being affected with TB, or infected, not affected, infected with TB. But what we've realized is that usually when people are still working in the high-risk areas, most of them don't present with signs and symptoms. It's after 2 or 3 years that they begin to develop the symptoms. So that's what she said concerning occupational TB exposure for healthcare workers. Now moving on to the theme of infection control. One of the categories that came from this theme is that hospital physical structures are not conducive for infection prevention and control. And this was said by almost all our in-depth interview participants. There were no dedicated TB isolation facilities in 2 of the 3 hospitals. Even one hospital, which was relatively newly built, had little consideration for infection control prevention. For instance, within the hospital, this is Hospital B, which had a TB isolation facility, TB ward, in fact. The participant said, even within that ward, which is relatively new built, there is no isolation facility. So patients all come, there's no way of triaging them. So also equipment for infection prevention and control is poorly maintained, such as biosafety cabinets and fans, and fans will see some of the codes concerning this in the next couple of slides. There's also no natural ventilation into patients' waiting areas, and some of the departments, as much as they wanted to do some, to implement some infection control measures, there were no, they had special challenges, so they couldn't really do much. All right, so this physician hospital ACEs, infection control, I don't think they had it in mind. And also generally, even for the hospitals, the way they're built, I don't think they had infection control in mind. This lab technician, this was in a focus group at Hospital B. He says, he was talking about a biosafety cabinet in their lab. He says, so it is totally down, and actually some guys, inspectors from CDC, actually they have condemned it because now what it is doing, it is aspirating the bacilli. It is not aspirating the bacilli out of the lab. It is actually now bringing it inside the lab. And you see we've been using it for some time, assuming that it was actually working, while actually it was not working for about 6 months. So this pharmacy technician says, yeah, it's central, talking about a building here where patients wait for their medications. He says, we cannot even talk of windows at that place. The only source of ventilation will be running fans, Like I said, it's an old design, and there's nothing much we can do about it. The only thing we can do is to just educate, education of patients. Right? Which in the end kind of puts the burden of prevention on patients or even healthcare workers. All right. Yeah, so he continues to say, but in terms of structural designs, it's pretty difficult. The fans are the only things that are involved in providing ventilation. Okay, so then in the literature we see that Sisolak et al. Out of South Africa conducted a phenomenological study looking at infection control measures, and they also found that the hospital that they were looking at had no designated TB wards. They also had lack of space. They also had limited natural ventilation. This basically the same thing that we just saw in the last slide. And Galgalo out of Kenya says, they did another study in Kenya, and in this particular case, windows were only means of ventilation. There was no triaging of patients. All right, so for the theme of barriers to implementation, there were several categories out of those. We had healthcare related barriers, we had institutional related barriers, guideline related barriers, etc. But we only look at this institutional one for now. So we found that there's lack of communication between healthcare workers, the implementers, and the policymakers and leaders and workers in general. There's also limited resources. For instance, there's a shortage of healthcare workers. One example, one infection control officer who actually used to be a nurse gave an example of, sometimes you have 2 nurses working night shift, caring for 76 patients with only two nurses. And then personal protective equipment, in particular the N95, because it's expensive and it's only distributed to areas labeled high risk, such as the emergency department or some medical wards. So lack of resources, again, there were no separate funds to train healthcare workers in TB exposure prevention in healthcare workers. So the workshops and the training that was done, and I had a chance to attend one of them while I was during the data collection, were actually funded by external organizations such as the CDC and some of the American organizations that I involved on. But the government itself at that particular time didn't have any covers that are particular for this particular thing. All right, so here this focus group talking about the theme barriers to implementation. She says, what I've realized is that policymakers, like the same. They adopt things from the books made by the Americans or the what, like they'll say, we have 2% mortality rate due to TB, but they'll never take into account whether that we don't have those ventilated, like you said, pressure what. We have never had those pressure things. They are just American things written in the books, and the next person who's going to review the policy is going to write the same thing, is not going to review what has been failing us. So these are some of the things that they felt, the participants felt that there were barriers to implementation. Okay, so out of the barriers to implementation, we came up with a concept called armoring. And this was from what healthcare workers themselves, they talked about this concept. Huipapana is actually a Setswana word which literally translates to, it's normally used in the context of military when the soldiers are fully geared for war. So this is, and I'll show you a code in the next slide here, which talks about this particular concept. All right, so this is a focus from focus group 1. This cleaner says, they come armored, talking about the healthcare professionals, the nurses and the doctors and others. They come armored knowing that we're bringing a patient, knowing what is needed. If they find you on duty, they'll not tell you what is necessary for you to protect yourself. They're at that point just focusing on the assistance they need from you without telling you what you need to do. So that's where the concept of armoring came from. So that kind of concludes some of the themes we wanted to look at today. But in conclusion, what I wanted to say, in reference to all the studies that are coming out of South Africa in terms of infection control and occupational health, we wanted to say there are other studies that have been conducted in Botswana, but this is the first study of its nature in Botswana. And we've kind of realized that there was discrepancies between the perspectives of policymakers and leaders and healthcare workers as far as TB exposure is concerned for healthcare workers. And also the other thing that we realized is that the dialogue on healthcare worker TB exposure is going on without the expertise of occupational health and safety personnel, which I'm sure everyone in this room would be like, that is something, we need to do something about that. All right, so some of the recommendations then that we came with from this is that WHO has a strategy called Stop TB Partnership Goal, which the goal of that strategy is to eliminate TB by the year 2050. So we thought that Botswana as a country could look at maybe adopting the strategy too, and it's reaching hard, but they could adopt that as a goal to try and look at implementing strategies to finally get to the elimination. But in the sense, maybe we can really talk about controlling TB, not necessarily eliminating it, controlling it. Because even before, back in the 50s and 60s, it was never really absolutely eliminated. It was controlled, so we could go back to that. So under engineering controls, then, they could consider occupational health and safety during building of hospitals, that they should include hygienists, for instance, occupational health people in the committees or task forces that are building hospitals. And they could help with installing engineering controls. Another thing that needs to be done is to evaluate healthcare worker TB rate. And also they need to train occupational health and safety personnel who can actually do the evaluation of rate. And also finally with PPE, personal protective equipment, even though they were distributing respirator N95s to high-risk areas, there was really no respiratory program in place which did things like fit testing and making sure that the N95 is available. So that's one of the things that they could do. All right, so at this point I would like to acknowledge some of the people who were instrumental in this research. My supervisor, Professor Karen Bartlett, who's my mentor supervisor, has been really fundamental in me getting to this stage. The UBC 4IF and UBC Bridge program for funding, the hospital superintendents and matrons who really were instrumental in getting together some of the participants, the healthcare workers themselves who participated in this, and my research committee, Dr. Elizabeth Bryce, Dr. Kim McGrail, and Dr. Chris McLeod, and Dr. George Astrakianakis, who was actually my co-supervisor until just a couple of years ago. And some friends that I see here have been really instrumental. So thank you. And at this point, I'll take questions.
Thank you so much, Bojosi. I am going to give you a second, turn on the light, and then we'll take questions. So I will start with the questions that were asked from our remote listeners.
Okay.
And I'll just go as they came across my screen. So we have, the first one was asking you, do you know what the incidences of other diseases are compared with TB? And I think this question comes from the fact that this person is wondering, are there more serious public health issues which take away from focus and or resources from the TB issues?
Well, I mean, HIV, for instance, is one of the diseases that have the highest incidence in the country. So if HIV has a high incidence, it goes without saying that TB incidence is going to be high. I don't know other infectious diseases, the incidence of them, HIV in particular, that I know that the incidence is relatively high for a warrant attention for TB. And there's also a whole department at the Ministry of Health, the Botswana National TB Program, which is dedicated to looking at TB.
Great, thank you for this. The second question is concerning the last part of your presentation. Yeah. So really thinking about what can be done with regard to what you have found in all the teams that you communicated to us today. So do you know of the engineering controls that are used in Botswana hospitals? If they have, any UV disinfection or improved ventilation of TB wards? And if so, what are the healthcare workers' reviews on those controls, their maintenance, and understanding of how they work to protect transmission?
Well, engineering controls in general, what usually happens here, if people have no idea about this, in this part of the world, you have negatively pressurized isolation rooms with air changes that make sure that the TB is taken out of the rooms, etc. So if they're talking about infection engineering controls in that regard, there's really nothing like that in place. There are some wards that are able to just use natural ventilation by opening the windows and things like that, but there's no UV radiation. And also in one of the newer hospitals, they have a TB ward. So in fact, I should mention that what happened when HIV, during the HIV advent, because there were so many HIV patients, the buildings which used to be for isolating TB patients were then given away for HIV. So which meant that now, because they're occupied by HIV patients, there are no rooms for TB patients. So there's really there's no engineering controls in the sense the same as here, if that's what you mean.
Thank you.
Thanks, Bojosi, very much challenging. It's a challenge, but I'm taking away from your presentation. Although a glimmer of hope, maybe, if I understood correctly at the start of your presentation, you said one of the hospitals does have an OHS committee. Is that right, compared to others? And I'm just wondering about that hospital and how that came about and whether that's a real opportunity for making some changes, or in the current climate, why that particular hospital might have that, and if it's, you think, able to enact some positive changes.
Yeah. So what happened with that particular hospital is back in 2009, one of the persons that I interviewed here, I was actually working with that in that department. He was my supervisor at that particular time. We went around different hospitals. They had a project where they were piloting it at that stage. They wanted to go to all the hospitals and educate the workers on beginning occupational health and safety committees in different hospitals. And so this particular hospital, took it up and they started a committee then. I guess the others kind of didn't.
Thanks, Bojosi. I was wondering if, building off of that comment, if you know of any progress in terms of the draft guidelines, if they've been finalized, or if what you saw from the draft would address any of the issues that were raised by your participants.
Good question. I don't know where it is now. It's because I didn't follow up with it in particular because, I was under strict instructions that I shouldn't use it. But the act, I did look at it. I did look at it. It wasn't particularly focused. Like if you open it, there's nothing in there that says if you have TB patients, you should do this in an institution. It just gave basic principles of what to do in a setting as far as occupational health and safety is concerned. So my guess is from that policy, then there are going to be guidelines that will be developed using that policy, and then standard operating procedures and all that we developed from that.
Thank you, Bojosi. There's, I think there's a comment. If you give me a second, I'm going to retrieve it for you about your talk. So, so this is from someone who wanted to make a comment about the fact that what you presented is characteristic of the healthcare industry worldwide. BC healthcare has some of the highest accident/illness and worker compensation costs I've seen across many industries. So what do you think of the comment? And I'm going to add a little question from my own. What is it that you know that we have here in BC with regards to how we handle TB from healthcare workers?
Yeah, well, yeah, it's a comment that we have we've actually talked about that. Yeah, even here there are, certain. It's not like it's absolutely challenge free. There are challenges that the health system even here still has to grapple with. Well, in terms of comparisons between Botswana and here, for instance, here they have engineering controls, which is, as hygienists, we know that is, one of the most important things as far as controls is concerned. They can isolate patients, they can make sure that the environment is as bacilli-free as possible. So those are some of the same things that are important and that are different between here and there.
Oh, yes, there is a question that I may have missed. Hold on a second for me. There we go. So it says, so this is from our remote listeners again. It says in CDC website, it says that, quote, KISS does not spread TB. But what about breathing in the exhaled air from a TB carrier while kissing?
Ooh. Kissing. Well, I suppose they may say, the CDC website, the reason why they probably don't say it doesn't is because they're probably thinking more of transmission through, the possibility of transmission through droplets, and TB is not transmitted through droplets. But I'm not sure if maybe there might be a chance. if there's obviously breathing and coughing. As long as I guess there's production of bioaerosols, there's a chance.
Okay,
But
well,
I'm
with
sure
this funny and, interesting question, I would like to thank you and invite everyone to join me in thanking Bojosi for a very, very interesting talk today. Thank you so much.
Oh. Thank you. Oh.